You are welcome to my channel. Thanks for visiting. Today, let's quickly go over infective endocarditis diagnosis using cardiac imaging. Without further ado, let's go. Before we get there, we need to know that the hallmark of infective endocarditis is the inflammatory changes in the valvular tissue at the attachment of vegetation. There is a separate full presentation on vegetation and microbes, including mycotic aneurysm, that have published. That will be attached right here. Fever will continue as long as there is bacteremia. Generally, the diagnosis of infective endocarditis will take us through some areas. It is necessary to know the culprit. So, first of all, we'll have the clinical judgment by going through the history, clinical features, that is signs and symptoms, physical examination, particularly peripheral stigmata of infective endocarditis, like you can see the heart through the hand. Risk factors that could be associated, there's a separate presentation on this. You can check my channel for that. We'll head to the lab, microbiology, and of course cardiac enzymes to rule out myocardial infarction. And then radiological investigation, which is what we are going to do today. Echo. We can have transthoracic echo or transesophageal echo. Most of the times, we'll start with transthoracic echo. Then we'll follow up with transesophageal. But sometimes we can go straight to transesophageal echo. When do we need echo? Once infective endocarditis is suspected, then we'll go for the echo. Here's the question. Is it possible to have echo-negative infective endocarditis? Yes, it is possible if the vegetation is too small or if the vegetation has already embolized. You can have echo-negative infective endocarditis. What will echo reveal? Echo will reveal valvular dysfunction, hemodynamic severity, ventricular function, the presence of shunts, and while following up in the face of bacteremia and deteriorating patient that's on treatment, echo will guide blood. Echo is said to be positive for infective endocarditis when it is revealing vegetation or there's an abscess, or both, or when prosthetic valve is showing dehiscency. So we can say that the echo is positive for infective endocarditis. Is transthoracic echo the first to be employed? Yes, in most cases, the transthoracic echo will be the first to be ordered. And then we'll be looking for vegetation, but the absence of vegetation will not probably rule out infective endocarditis. So it doesn't mean there is no infective endocarditis if transthoracic echo cannot pick vegetation. The chances of infective endocarditis is lower when transthoracic echo is revealing a normal valve with normal function. Is transesophageal echo superior to transthoracic echo? If that is the question, the answer is yes, it is superior to transthoracic echo. And let me tell you some facts about that. Transesophageal echo sees valvular perforation, can see the abscess of fistula, even aortic pseudoaneurysm. We must have transesophageal echo once TTE is positive. Even if TTE is negative, but with a high suspicion for infective endocarditis, then we must embark on TEE. If TTE is inadequate, then we must do TEE. TTE is positive and you have treated the patient, but you are not winning, then do TEE to know exactly what's going on. TTE is showing valvular regurgitation, and then you need to make up your mind whether or not surgery will be required, then have TEE done. So TEE is more superior to TTE. Is it possible to have false positive TEE? Yes, it is possible. We can have false positive transesophageal echo when there's cardiac tumor, when there's mural thrombus or fibrous strands on aortic valve. You need to have TEE, but there is pacemaker and fever. Regardless of the outcome of TTE, we must have TEE done if anyone is on pacemaker and at the same time having persistent fever with or without murmur or bacteremia. We must have TEE done. The question can be that is it possible to skip TTE and have TEE done directly? The answer is yes. You can jump TTE and go straight to have TEE as a first echo to be done when the individual is already known to have infective endocarditis in the past. So previous infective endocarditis can warrant TEE as the first echo today. Also, when there is past valvular abnormality, then you can have TEE done as the first echo. Lastly, when TTE is difficult because the individual is endowed, meaning obesity, or chest wall deformity is constituting hindrance, or mechanical ventilation is in situ, then you go straight for TEE. Another question is, can we have a repeat TEE? Yes, we can when the TEE that has been done previously has come out to be negative, but you are so pressed with high degree of suspicion in this patient who have presented with persistent fever and peripheral stigmata of infective endocarditis are just so obvious, or there is no other cause or causes of the persistent fever that you are dealing with right now, and newer cleaner features or complications are already showing forth, then we will repeat TEE at least 1 week after the first TEE. Now, cardiac CT. When will cardiac CT or fluorodeoxyglucose positron emission tomography become necessary? Yes, if both TTE and TEE are non-diagnostic, then we have the alternative, that is the cardiac CT. Fluorodeoxyglucose positron emission tomography with CT will also be helpful when planning for surgery in patients with extravalvular complications. Cardiac CT is more informative than echo. When TEE is precluded by artifact, cardiac CT will be a better option. Cardiac CT is superior to TTE and TEE for paravalvular extension of infection and abscess. For the evidence of embolization, CT of the head and chest will be better. Though cardiac CT is fine, but not without demerits or not without shortcomings. And the shortcomings here will be that transesophageal echo, that is TEE, is better than cardiac CT to diagnose vegetation. Other radiological investigations that we can make use of will include EKG, and of course elementary with serial EKG. And you know what I'm trying to rule out, right? Then we can have chest X-ray. These will add cardiac enzymes to this, but I'm limiting this presentation to radiological investigation. We can have chest X-ray when we're suspecting septic emboli of the pulmonary system. Also, the infiltrate with or without cavitation. And of course, that will help with congestive cardiac failure. Then we have non-cardiac CT of the chest, abdomen, and pelvis, because we might be concerned about metastatic infection, like going to the splenic vascular supply, giving splenic infarction, renal infarction, Suarez abscess. Then that will help us to determine the need for a localized drainage. And lastly, magnetic resonance imaging. This will be helpful to rule out certain complications like vertebral osteomyelitis. Remember, if vertebral osteomyelitis is involved, the individual will be on antibiotics for a very long period. And also, MRI can help with intracranial mycotic aneurysm. I have a several presentation on mycotic aneurysm already published. Also, central nervous system bleeding. If there is associated headache or neurological deficit, with or without meningeal signs, magnetic resonance imaging can help greatly. With that, I've come to the end of radiological investigations when it comes to infective endocarditis and some possible complications of the same. Thanks for listening. Please remember to subscribe. Remember to share this on your platform. I appreciate it.